Good morning, all. Those of you I've met and those of you have not. My name is Barb Opperwall. Please call me Barb. I'm a nurse practitioner, and I have had the privilege of working with this group for a very long time now. I am formerly with the Trillium Palliative System and appreciate the opportunity to share something I'm very passionate about. I chose a light blue wall in my home for a first-time Zoom because I had dismantled my Zoom clinic in my house, and I'll never use it again because it's really dark, so I apologize for that. I'll let you know that I am notoriously oblivious to the chat, and so someone will have to poke me when the chats come, and if I pull the share screen down, I'll try to be attentive to that. We can have questions at any time, but unless you verbally break in, I'll be oblivious. And I'm sure you appreciate the irony of having a conversation about effective family conferences over a Zoom platform in which I can really not see any of your faces. So we're going to talk about that a little bit more. I'm going to take the time to share my screen, and we'll get going. So again, good morning. This is about effective family conferences. I have no disclosures. The photographs you see are from this month for me, and we'll play a game of questions at the end to see where I've been. And so, yes, obviously I'm having a little bit of jet lag. The objectives for our conference. We're going to talk about how to get ready for family meetings, how to conduct an effective family conference, what kinds of things influence them, how to talk about really tough topics, and how to know what you bring to the meeting. What are they? What's a family conference? It's a meeting between the patient, their family, and healthcare professionals. The goals are to share information, to clarify what our goals are, both us and the patient and their family, to talk about prognosis, diagnosis, treatment, and to develop a plan of care, both for the patient, the family, and probably for us. It takes a lot of skill to lead a really tough conversation. And remember, we approach any professional situation with preparation, with practice, with experience, and with a plan. So people who do really good family meetings, they are not just winging it. And we all know that some of us are better at it than others. And I don't necessarily appreciate the kind of crude thing that some people are able to bring it home and some people are not. But it really does take skill to lead a difficult conversation without alienating, particularly the patient and or the family member. And so we'll talk more about that. The kinds of skills you are going to need are group facilitation skills, and that typically is not taught in a lot of our professional backgrounds. We might have it naturally. We might have that art intrinsically. We can learn it. You need to have empathy, and empathy is something that can be learned and practiced. You need patience. I'm notoriously impatient, and so patience is something to learn and to practice. You need to have counseling skills. You need to know what the patient's medical condition and their prognosis is, and you need to be willing to provide substituted judgment, guidance in decision-making. So where does this all happen? It really happens pretty much anywhere the patient is and or the family is. It can be in the hospital, in acute care, in critical care. It can be in a hospice setting. It can be in any kind of living facility for patients or any kind of rehab facility. It can be in a home. It can be in a clinic, and it can be virtually. It can be anywhere you are. So why do we do this? Again, we provide information at a pivotal point in the patient's process. We clarify things. Particularly when communication is confused, we really define the plan of care. We are trying to get the patient and the healthcare team on the same page, and we use it to provide support to the patient and the family, particularly at a very difficult time. I like to think about this, and I think it's appropriate to think about this in terms of who are the customers we're working with. This intervention, this process, a family conference or a family meeting, has customers. We're one of the leaders in this. We're the provider of the service. The customers are not just our patient, but also the referring providers, the people who ask us to help. The family other caregivers, and other staff. I'm going to say one more thing about customers. If you forget to consider all the customers, you're more likely to struggle in your personal goals for the meeting. So you do have a role in the meeting. You are the host, and that's sort of a novel way to consider it. But a host is more than just the medical provider, the healthcare provider coming in. A host is the person who really makes sure everything goes well and makes sure all the people who are there, who are present, are comfortable and are experiencing things well. You're also a provider of care, usually to the client or to the patient. You're a facilitator of this conversation. You're a mediator of conflict, and you're a translator of complex healthcare language to those who don't have that background and understand that language. And that can be really tricky because I truly, after many years in healthcare, cannot remember when I did not know some of the words, some of the difficult words. I will never forget when my mother, who's aging now, she's just about 90, was had a UTI, and it got complicated, and she was in the ICU at a local hospital, or in the ER at a local hospital. And I was up north, happened to be wine tasting. And my sister, who took my mom in, is texting me from the ER and spelling out LEVOPHED. What is that? Because the ER people were giving these words so quickly. And when I knew it was Levophed and she was in shock, then I knew I had to get down there. And so just be aware that some of the words that are natural to you are not natural to the people you're speaking with who are present at your meeting. So every conference really has goals. And again, we talked about them earlier: inform, clarify, define, plan, be on the same page, supporting, etc. The goals are not only for the patient and the family, but for the medical team and for us. So think about what you know about your own decision making, particularly in a crisis or under a time pressure, or when you don't feel well, or if there is pre-existing conflict or relationship stress in the situation. When I'm in a crisis, I get a little bit excited. When I'm under a time pressure, I get anxious. When I don't feel well, I'm crabby. And if I'm mad at my husband, we're a little snipey with each other. It's potential. Be ready for subtext for meetings, not just only about your own decision making, but be sensitive that many of the people present in the room have stuff going on that's not just in the conference. The staff might have had conflict together or with their family members, or be dealing with financial issues. The family may be struggling with cost or with transportation or with jet lag. So just beware that in the decision making in this conference, there can really be a lot of subtext, some of it critical, some of it just there. Be sensitive to it. So what bias, and I want to just touch on this for a minute. We'll have a whole conference talking about implicit bias, but what bias do you bring to the conference, and how do you manage your own bias? What are you bringing to the table? So we're going to take a real life case. We're going to take a tall female who's 5'10" in her socks and has big hair, and she's white and has a lot of privilege. She's affluent, she's healthy, she's bossy, she's self-determining, she's socially supported and expects truth telling. All those things that obviously I bring to a conference bias the situation, because not everyone in the situation is going to enjoy my white privilege or affluence. Certainly not everybody in the room is going to be healthy. And not everybody is necessarily going to think that truth telling, particularly in some family situations and or cultural situations, that is the thing that has to be done in the situation. And certainly not everybody is socially supported. So those biases will lead you to skim over things, or can. And so just be aware of what you bring to the conference. And I also want to mention, I have a resting cranky face, crudely called RBF. I have a resting cranky face. And so I have to really, literally, consciously, when I'm thinking, not be scowling with a furrowed eyebrow. I have to seriously think about bringing a sincere smile to the situation, not a artificial one or a false one or an inappropriate one in a difficult situation, but to be approachable. And that may be a situation for you, and you really Probably want to check with your peers or with others around you to figure out what you bring to that meeting and ask for some honest feedback about it, because it can inadvertently sabotage your ability to lead family conferences effectively. It is also important for you to decide whether or not you care about the customers. Do you care about the patient, or are you kind of struggling with that? Is this a person who you just cannot connect with, or who has been adversarial with you? Think about your referring providers. Do you care about them, or are you thinking, they got us into this position? Those attitudes really block or interfere or sabotage your ability to effectively move forward. Do you care about the family? Are they like you? Are they not like you? And how does that make you feel and experience the situation? Do you care about caregivers for the patient and for the situation in the facility? Do you care about the staff, or have they been not helpful? I'm sure we can all speak to walking into a facility and wanting something as simple as a wait and finding out how difficult it is for the staff to get that to us. And we think such a simple piece of data, and I, can have some attitude about that, realizing, okay, I don't know what that staff is going through or how hard it is for them to find it. Do you care about them enough to sort that through and recognize in yourself what you're bringing to it? Or if your attitude, which is standoffish in some way, is going to affect the entire meeting and affect your interaction with your customers. I want to touch on whether or not empathic communication skills can be acquired. Empathy obviously works much better if it's not an act. And it's well known, I'm using a Teddy Roosevelt quote, no one cares how much you know unless they know how much you care. Can you really connect with the patient with empathy, with presence? Believe it or not, as little as 40 seconds of emotional support, less than a minute, is associated clinically with a lot of reduced anxiety among patients who have to make difficult medical decisions. And the reference is there. It's a little bit old, but it's just such a solid reference. Please beware that if you're uncertain about whether you really have supportive and empathetic feelings for patients, and this is not the only thing, but if you can't connect and begin to connect, that's an area for you to start to develop some skill. And there's a lot of really great information and literature out there, and it's not all in the medical literature, by the way. So what's the evidence for family meetings? Believe it or not, some of you know this, but my original thesis way back before most of you were born was about family meetings in the intensive care unit. And it actually was part of what changed the prior 5 minutes for a family to meet every 4 hours in the ICU to kind of open visiting hours. And so I didn't single-handedly make that happen, but I was part of a greater project that was really effective in helping that. So please know, original research about conferences and family meetings is in the business, psych, anthropology, and education literature. It's not in the medical literature. It's not in the nursing literature. But our social workers and our colleagues in business, psych, and other fields really establish the importance of the elements for having meetings and having negotiations and having conferences together. There is well-established research on family meeting formats for ICU patients, for onc patients, for surgical patients, and for many, many more. You just have to dive for that. Just enter family meetings, family conferences, difficult conversations. Those are your keywords. But we all know it's really hard to do a double-blind study on human interaction. And so some of the research will be phenomenological, which is the study of an individual or a small group's experience. Kind of a challenging quote is from Brene Brown, who not only is famous in pop psychology, but also has some really deep academic credentials about the study of people's experience, and particularly about empathy. She would suggest that maybe stories are data with a soul. I challenge you to seek the evidence about family conferences and be a little bit broader in your understanding of stuff worth reading, and learn about this what you can, and venture out into some of the literature in our satellite fields. In our palliative medical and nursing kind of models, there is huge reference called the Spikes model, and this generally is addressed in both board exams for nurses and physicians. And it's a good guideline for setting up a family conference. It's the setting of the interview or conference. It's the patient family perceptions, understanding those. It's getting the invitation to share knowledge, to do the actual knowledge sharing, to address emotions with empathy, and then to strategize and summarize. And I'm going to move through this quickly, but the slides will be available afterwards. And you know that's available in your study materials. I want to touch briefly on the decision maker on a family conference. We're going to have a whole session on this, I think, in a month or so. But it's really about who gets to make decisions in the conference. And at that point, we'll be looking at whether or not the patient has the capacity and or the competence to make the decisions, whether there's a medical durable power of attorney and whether that's been confirmed, whether that's formal or informal, whether there's a guardian present, whether we use family consensus, and what part providers play in the decision making. I'm just alerting you that there's a lot of material in family conferences just around decision making that gets its own hour. And so we can have questions about this if you have them, but we will be touching on this more thoroughly in a little bit, in about a month. So back to the Spikes model and starting with S, the setting. So as the host of the meeting, you or your designee is going to really be looking at the available patient information, and you may even need a meeting before the meeting, either with the referring providers or with the family, just to say, hey, we're going to be having a conference. You are responsible, whether it's you or your designee, to make sure that there is a comfortable space for that. And doing this at the last meeting, which often is unfortunately what we have to do, isn't always effective. It can lend to a lot of initial chaos. And so I encourage you to have some sense of where the room may be ahead of time and kind of work with that. And here's where really looking at your staff customers can make a huge difference for you, because if the staff is on your side and they understand what you're hoping to accomplish and they understand what they can appreciate about that, they can be really super helpful. Pay attention to the seating. The alpha or standing position and the beta or seated position really is not helpful to conferences and family who've been uncomfortable and not a good place to sit for a long time. If you can't find chairs for everybody, kind of know how many people you're going to have and try to see if you can get some help and have adequate seating. You never know in the setting what you're going to find when you get in there. It might be the leftovers of a staff party. And if that stuff's around, just kind of don't slide in at the last minute, but be aware, or have your designee be aware and help to make sure that the setting is well prepped. Please be aware also that you may end up having two meetings. One, which we call the firing the warning shot, which is, hey, we have to make a decision about code status, or hey, we have to talk about some really hard things and you have to let us know what the patient would want in this situation, and then give some time, whether it's hours or a day, and then the decision meeting. Special considerations for meetings that can't be face-to-face. So we went through the pandemic and we're watching a rise in the tridemic that may potentially happen, and we're all a little sensitive about this. And so just be aware that you're comfortable with virtual meeting platforms. One of the things the pandemic and the legitimization of virtual meeting platforms is it permitted us to now really bring in family members who are at a distance much more easily. A lot more people are savvy enough to come in on FaceTime or in a virtual meeting, or even use Zoom or some other secure platform that your organization prefers. That really has helped us to incorporate a lot more people. So there are some advantages to it. But also beware that if some of you in the meeting look like this, I'm putting on my KN95 here that I wear on occasion, it really affects the perception of the patient of your humanity, because it really puts a barrier between you and the family. So beware of that. Virtual meeting platforms, though, can be extremely useful, both for whatever reason that a meeting cannot be face-to-face. You can obtain telehealth consent. It just requires appropriate witnesses, and your organizations will have those procedures and policies. You want to be really careful to maintain confidentiality virtually. And so be sure that you do that, especially if you have earphones in, but you're in a public place and you're talking. We don't always realize how much our voice might be carrying. Even though we think the meeting is confidential, it may not be. Be sure again about your setting, and I've really failed my setting today inadvertently because of the darkness and the poor lighting. Be sure to assist the patient and the family to participate. And so be sure that you have some savviness or you have a designee with some savviness about bringing people in if they can't be there face to face. So now, opening the meeting. I want you to make sure the patient is comfortable, whether they're present or not. There will be plenty of meetings when the patient will not be able to be present. If the patient can't be present, it was my habit to briefly and earlier in the day go to the patient's bedside and make sure they were comfortable. There is nothing worse for just disrupting a patient and family meeting or a family meeting if the patient is miserable. And so you will remember this later, that it is well worth double checking to make sure the patient is comfortable, whether they're present or not, before you get started. I really encourage you to sit down. It makes you human. It makes you face to face on conversation, and it brings social community to the meeting, to the conference. It brings you together with all the people who are there in that same posture or position. Instead of being oppositional battle formations, we're at conference or communication positions. Take the time to verify that everyone who needs to be present is there, whether they're in body or in virtual methods. I encourage you to make introductions and acknowledge every single person in the room. And this is particularly helpful because you need to chart exactly who is there. It can really be important later. And so be sure you have the names. And if you're not writing them down, be sure you have a designee who's writing everyone down. I'm someone who did not always remember names, even if I was going quickly around the circle without making a connection. So I made the habit of making a seating chart so that I could address people by name later. And it makes a huge difference. Introduce what you're bringing, the palliative care service or hospice service, to the group and tell them what the purpose of the meeting is. You're going to get the meeting started by inviting everybody present to tell you what they know about the patient's condition. Some ideas for phrasing are, tell me what the doctors or the healthcare team have told you about the condition or the patient's condition. Can you describe for me your sense of how things are going? Patients and families often know a lot more than either of them think they do. And often families think they're keeping secrets from patients, and the patients very regularly know what's going on for sure. And so it can sometimes be a time when you can facilitate the patient and the family to understand with each other. They both know what's really happening. Another conversation that can be really helpful to give context, particularly about change in status and decline, is to say something like, tell me about your past 3 months or your past 6 months. What type of changes have you noted? At this time, you can also explore how much does the patient really want to know. It will vary and it may not match your own values about that, but how much does the patient want to know? And be sure that you honor that. You're then going to provide information. Ask politely, can I bring you up to date about what's going on? Give a good, tight summary of the condition, the current condition, and try to minimize medical jargon. If you give medical jargon, spell it so that people can write it down, or write it down and give it to people later so that they can look it up. They're going to want to, and they're going to respect that you don't have a problem with that. People sometimes think that we use vocabulary to gain status or to intimidate, and those are not helpful in getting good decision-making to occur in a difficult situation. Review the burden of suffering versus the benefit of any treatments that you have to discuss, and help the family understand what is being done to keep the patient comfortable at the current time. Sometimes patients come in miserable. They might have a bowel obstruction. We get them cleaned up and perfectly comfortable with good medications and sometimes even sedation. And they look so peaceful and comfortable, the family cannot understand the criticalness of the situation. And if someone's got a good blood pressure in the ICU on the monitor, but we've got 3 pressors wide open, families don't understand that those IV bags are maxed out. They don't understand it. So you're going to really have to help them understand what we're doing now. And if we do a really good job of keeping patients comfortable, inadvertently, the message to the family can be, we don't have to do anything yet. The things we got under control. Be careful. I'm not encouraging that we let patients suffer so that families can see the difficult situation. I'm saying be sure everyone understands what we're doing and where we're at in that treatment curve. It's okay to talk about short-term and long-term plans for any bridging therapies, and we can go into detail about that for anyone who's really interested. It's really easy for us to ramble on, to talk and talk. I am a talker, many of you know that. And so I have to sit on my hands because I also talk with my hands, and I have to actually count seconds so that I don't ramble on all the time. Listen, give the people a time to talk. When you've shared your information, they've asked their questions, give a bottom line statement, such as, it is no longer medically clear which option, or we have a significant concern for suffering in this situation, or despite all our best efforts, the patient is continuing to get worse. Oh, we do not expect this to improve, or time is likely very short. We can talk again. There are many good ways to give a good bottom line statement. Allow silence. And silence really means 5 to 10 seconds. And so I'm going to take a 10-second silence here so that you can feel it, because when you're talking with people, 10 seconds is longer than you think. And this means you. And in that silence, we know statistically, most people want to respond within the 5 seconds. So I'm going to take the 10-second silence now. So 10-second silence is so uncomfortable for me, I practically have to break in to talk to you about it. But I encourage you literally to count it out when you're looking for response. And at the time, don't look down. It's a really good time to look everyone in the eye one by one to make sure that, and to check to see if they have something more to say. And it's a really good time to say, oh, Susan, it looks like you're thinking about something. Did you have another question, or was there something you wanted to add? When you look people in the eye, particularly people who might be quieter in the group, and that there is silence for them to speak into, you can get some really good information and really wise words from family members. So a couple of situations. What do you do when the family says, don't tell the patient? I encourage you to ask them, help me understand why you don't want me to tell them. Is there anything you're afraid I will say? Do you have previous experiences that didn't go well? Check to make sure there's not a personal, cultural, or religious context. We will have our session. You will have your session on cultural situations, implicit bias, but there can be some important cultural reasons, particularly where the patient is not to know, and work through with that. It is not obligatory that the patient knows every single thing, although our value is that if we want to know their wishes, we need to hear their voice. But if your patient doesn't want to know, explore that, but respect it. It's also really good to offer to talk to the patient together with the family and walk that way together to find out what the family needs to know. What do you do when the family says she or they are a fighter? So our favorite response, most people are fighting to live as long as possible with the best quality of life they can. We've had the strategy of fighting the disease, but that strategy is no longer working. We need to consider a strategy directed towards comfort and quality of life and fight just as hard or harder for that. Be attuned to conflict. Conflict can result in information gaps. It can come from information gaps. It can come from misunderstanding. And in a stressful situation, you can say something and ask someone to say, now, how did you understand that? Tell me what you heard me say. And they'll say the opposite of what you said or meant. And I don't have all the understanding about why that happens, but really recognize that can completely sabotage your conversation. You can go, what happened? be aware that misunderstanding can really, really be a barrier. Look at treatment goal differences. The goals that you have, the goals that the patient has, the goals that the family has, the goal that the providers have may not be the same and can create a lot of conflict. In a difficult situation, there are going to be a lot of emotions present. Just no surprises about grief and guilt and anger and hope and many, many more. Be aware of family dynamics. Sometimes in a family meeting, when you bring all the siblings together, some of them may not have seen each other for years or decades, or there may be conflicts that are in the past or that are in the future, particularly about estates, anticipatory conflict. Just beware. And be aware that there can be a lot of mistrust of a medical team culturally, racially, experientially, socioeconomically, and if we're bringing this affluent, particularly white privilege to a meeting, be aware that that can be conflict walking in the door that you have to get past before you can make any progress in what's going on in the situation. And I'm screaming at you, be sure to listen, because when you listen for that, rather than just speaking it, but listening to what they're saying, it will really be directive for you in understanding how to make this family meeting helpful to all. In a situation when the family needs to make a decision, some phrases that could be helpful. There are some things it would be good for you to talk about together. Respect the family system and the boundaries. The family matriarch or patriarch may not be the decision maker, but that's still the family system. And we are not part of the family. Bring in any virtual way, people who cannot be present, because we all know from situations that we've experienced that we're all doing great until the sister from California gets here, and it's like no conversations we've had have ever happened. Be sure you get everybody in who cannot be present. And if you have not asked who the family is and who should be there, that's going to just shoot yourself in the foot about getting your conference. And again, spell medical terms for the medical family member or their friend who is probably a nurse. Assist with substituted judgment. That means bringing the patient's voice into the process and framing decisions around the patient's goals about specific treatments. One of the most effective phrases, and it really comes from John, is, given what you have told me about the patient and what we know about their medical condition, I would recommend. It's okay to say that. It's okay to say that. It's okay if they don't agree with that, but it's okay to say that. I wouldn't start there. This is summation. This is substituted judgment and summation when the family is not sure where to go. And be sure you talk about the true benefit and burden. I rarely talk about pros and cons. I really talk about benefits and burdens because it's much more meaningful to patients and their families in understanding where to go. It also really helps you frame the burden of suffering. And I think that the burden of suffering becomes a really important consideration that may be new to the table for the family and the patient. I want to touch briefly on when a feeding tube is the question, and just reviewing the American Geriatrics Society Feeding Tubes in Advanced Dementia position statement, that percutaneous feeding tubes are not recommended for older adults with advanced dementia. Careful hand feeding is at least as good for the outcomes and complications. And then really being honest about the tube feeding potential side effects. And really understanding how to talk about pleasure feeding. Eating continues to be important to the patient, and given the age, frailty, and clinical decline, the risk of aspiration is acceptable. So accepting known risk. The risk of aspiration is acceptable in exchange for allowing the patient to continue to participate in day-to-day activities, including eating, that are meaningful for them. And as a sidebar, accepting known risk can be a useful phrase to you in many situations. And I will share with you that my mom, who is almost 90 and is really still kicking around playing games 4 nights a week and beating people at euchre, we are accepting the known risk of stroke and having her baseline systolic blood pressure be between 150 and 160. It makes her primary physician really uncomfortable that we have chosen this. But when her systolic is below 140, she is lethargic. And so, as we know in the kind of hospice situations, that we often get better brain perfusion, a little bit higher blood pressure, kind of towards the end of days. And, for her, but I have to use the words, we accept the known risk every 6 months when we meet her with her primary doctor. And so, as they're useful for you in not only pleasure feeding, but other situations, be aware of that. I want to touch briefly on removal of the ventilator when that's the decision. Again, frame the decisions around the patient's goals. I am not fond of compassionate withdrawal or stopping aggressive care, and we'll have many more conversations about that. But talk about what life support may mean to them and give short-term and long-term picture for options. And this is a time when a therapeutic trial can really make a difference, and setting time limits for conversation discussion can really make a difference. What we might understand as the benefits around life support and what family members and patients might understand really can be different. And so the conversation about the benefits versus the burden of suffering can be really huge here, because most people most people who are not in healthcare do not understand the burden of suffering around mechanical ventilation, or that it was intended to be a bridging therapy. You will have code status discussions. You can start with, have you ever talked together about how the patient feels about life support? Review the main aspects of full code, which are intubation and mechanical ventilation, CPR, and defib. And if their eyes are not glazed over, you can get into the supportive therapies like pressors and BiPAP and going to the ICU. I want to talk briefly about the partial code situation. It is highly symbolic to patients and families, even though we know that the support of respiration, the support of cardiac function, they come together. Compressions and intubation come together for us, but it can be hugely symbolic to patients and families. But yet you still also have to be honest. People will say, give them one shock. You can let them know this is really kind of an all-in situation. Some healthcare people will not do partial codes. And I'm not entering that conversation now. I'm just alerting you, it can be hugely symbolic for patients and families, but it can really, often patients will accept one, but not the other. And you can find a place of acceptability together in this kind of a plan. I do encourage you in those situations, of course, to do therapeutic trials of treatment, and be sure to say and to document, we will reevaluate this in blank days or blank weeks. I want to share with you just a phrase to keep in your mind if you're not already using it, which is, it can be extremely helpful to patients if you say, the healthcare team or the medical team would not be surprised if there was a sudden decline in condition. That's why we're having this conversation. We do not want you to be surprised either if that happens. This phrase really became part of my work early in my career, when someone who I knew was at high risk of a sudden coded overnight and ended up in the ICU and vented. And I went there the next morning, and the spouse looked at me and said, "Did you know this might happen?" And I was really taken aback, because I did. And she then proceeded to say, he would never have wanted this. Why didn't you talk to us about it? And that was transformative for me in my career, both in moving me towards a palliative focus in my career, but also in understanding, how do I raise a difficult topic like this? They deserve to know that you would not be surprised. You're not saying it's going to happen. You're saying, I would not be surprised if this went bad suddenly. I wouldn't say it like that, but you need to let them know. Sometimes unrealistic hope for a miracle is expressed. And if that is said, it's okay to say that you also hope for an unanticipated recovery as well, but that a miracle or a scientifically unexplainable event is what it would take at this point. And have them activate all their resources in that regard and explore that with them, because that comes under their spiritual care. And you have an obligation, if you can't provide that yourself, to find the resources to provide that for them. It's also okay to say, sometimes things don't go as well as we hope, and I want you to be ready for everything. If we get a miracle, we celebrate, but we want to be ready for whatever happens. Then you're going to bring your meeting to a close. You're going to establish your goals. What are you hoping for now? What's important to you? What are the things you need to do? Who do you need to see in your time that you have left? And what do you think the patient would say? Always, what do you think the patient would say in this situation? And then restate what you understand are the goals. What I hear you saying is, and make sure they agree, and then develop your plan and reiterate it based on those goals. This might touch on how they feel about future hospitalizations or going to the ICU or further diagnostics, about their code status, about use of a variety of interventions like blood or antibiotics or hydration, nutrition, or hemodialysis or device insertion, whether or not they're interested in a second opinion or experimental therapy. Listen to the treatment options the patient or family might bring into the conversation, particularly alternative treatment options, and then decide what is the disposition to best meet those goals, such as a hospice referral or transfer to rehab. Close up the meeting, restating how you understand the patient's goals and what the next steps are going to be. Check one more time to see if there are any questions. Let them know in a meaningful way that the family will not and the patient will not be abandoned, even if the choices they make don't match what's being recommended. Thank everybody who's there and gently exit, giving them some time together. Now, we all know some meetings really go bad. They go south fast. And it often wasn't about you. Sometimes maybe, but often it's really not about you, except that we missed what else was going on, the subtext. Also, some patients and families can be really hard to bond with or to connect with. If you blow it, you'll get another chance. Write down what happened, good or bad, who was there, exactly who was there, what was said, and what is next. It can be really important to document if you told all the appropriate decision makers. So be sure that who was there and what is next gets listed. Also, if you contacted everybody and some people didn't come, that can be really critically important. If there has to be another meeting later, it can save a lot of time about exploring who the participants need to be. I encourage debriefing with your team, with the staff, about what went well, what could have been improved, and talk about any emotional reactions or needs of the care team. There can be frustration if people refuse to consider a no code. There can be angst about the distress that happened in the meeting or the tragedy of the situation. Talk about those things and address them. Using my favorite non-healthcare provider, optimist, you're going to do the best you can with what's thrown at you. And then you're going to try again. There's some references, a starter reference list at the end of the slides, and we have time for questions. And I have some cases that we can go to. It's about 8:15, so I think I'm going to stop my share and go to questions first. Anybody, any questions or comments?
Floor is open, so please take advantage of Barb's expertise here and ask or comment away.
In a large group like this. Oh, go ahead. I'm interrupting someone. Go ahead.
Oh, sorry. Can you hear me well?
Yes. Although if you ask a question, if you're willing, I like to see your face. So start your video if you don't mind.
They've got to adjust their audio too, just for a moment there. There's John.
Hi, John.
Hello.
John is one of our fellows over at Corewell Health.
Excellent.
I just wanted to say that, okay, it's oh, can you hear me?
Mhm.
Oh, okay, so I just wanted to say that your background and lighting was excellent. It gives a professional looking. Yeah, everybody who every lecturer that I used for board prep actually uses similar backgrounds. So I think it's awesome. And secondly, you told us about this two meetings, where first meeting is like a warning shot, and second meeting is actually talking about what's going on or breaking the bad news. So, is there a study or any recommendation which one's better than the other?
Is there a study about that? I don't have a reference at my fingertips. The material about the two meeting approach is actually in the business literature. And that always makes people kind of roll their eyes, but it's in the negotiation literature. But it really is supported in phenomenological reports. And medicine is not real comfortable with anything that's not controlled double-blind kind of studies, but nursing and social work are a little bit more amenable to that. And so you'll find that, so there are some phenomenological studies talking about how the human brain can only accept so much news at one time, and it can be paralyzing. And so getting the warning shot is really getting the bad news and saying, hey, you guys need to talk about what the patient would want in this situation. And we'll come back at 5 o'clock, or we'll meet with you tomorrow at 10. And then we have to decide what we're going to do. And here are the choices. And then they have time to talk. They have time to think. They have time to formulate questions. And you can come back in the next meeting, the second meeting, and just say, okay, what questions do you have about those options? And often you're literally repeating it as though they almost didn't hear it because they can't quite believe it. But they'll also have, their nurse family member will have prepared a list of questions or be present. And you can go through those things and say, so what do you think the patient would want in this situation? What do you think the patient would want? And they have had that time to process the information you gave in the first meeting and make a decision in the second. So I will see if I can dig down and track down that literature, but I will share with you that it's in the negotiation literature in business stuff.
The other thing I would just like to kind of piggyback on that is that to remember that the first time you sit down with somebody, this is all brand new information. And it may be something that the other doctors thought that they had shared with them, but the way that you do that and the way that you communicate and the relationship that you develop and the language you use, maybe they're hearing something and didn't appreciate what the other doctors were saying because they use just the strict medicalese. And so they're hearing it for the first time. And as Barb just articulated, they need a chance to be able to process that. And those emotions that come out with the initial, with the initial salvo and may have a chance to temporize. They may get better, they may get worse, they may get different in terms of how they're now reacting to the news of what you're delivering. And so I think that's always the advantage of the two meeting approach. The other thing is sometimes the second meeting is longer than the first. The first meeting is to lay down the premise and the language and the circumstance, give them a chance to digest, and then come back and really now get into it when they can be more objective.
And again, if you use a two meeting approach, and you may have to, in the first meeting, determine, okay, is this going to go well? Are we going to be able to carry this conversation to decision making, or do we need to stop now? You have to be really attuned and present to how the people are doing the situation to be able to say, okay, I think we've shared the situation. I want to give you some time to think about this so that you have time to do any research or invite anybody else who you think wants to participate in it and talk about it among yourselves. And so it's 11 a.m. now. Does it work if I come back at 3 today? It can be the same day, or does it work? Do you want to have a day? Should we talk about this tomorrow? Anyone else? Any other questions?
Hi, Barb. Ken Hansen here.
Hi, Ken.
Hammered work. Just wonder if you had thoughts on pre-expectations, right? You get consulted by the care team and they dump all of these, issues they're having. and they have a goal, right? The goal is we got to get the patient on hospice, get them out of here. You know, they're paying, they're not, you know, the treatments aren't working, the family's difficult, blah, 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 blah. And then all those pressures piled onto you, and they expect results now. So I was wondering if you could just comment on that.
It's such an excellent question. So I think the two most common reasons that there are predispositions in consultation are for us to either get the code, get the DNR, or get them on hospice. We will hear that, you will hear that over and over again. And it can be in the acute care setting, it can be in the ambulatory care setting. That will often be the reason for the referral. And I encourage you to remember that referring provider is your customer. And it's not in a monetary way, I'm considering that, but that you want to build relationship there, because the fact that was asked of you lets you know there's so much you can teach them and such a relationship you can build about what palliative care can do for them and for their patients. And that's a process. It takes time, it takes relationship. And so being mad at them or frustrated or alienating them is not going to help you or help their patients or the patient in question. So recognize that referring provider despite that unfortunate reason for referral. The second is to have a response in your head, because many of us, if someone says something essentially obnoxious to us like that, we don't have a response ready. And so if you're not really extemporaneous in your speech, have a response ready along the lines of, I really appreciate your referral. It sounds like you have some significant concerns about the patient, and I will absolutely keep your and your patient's concerns at the top of my line. Tell me why you think this is the most important thing. So get them to tell you about that. And they will typically have an explosive amount of frustration to share with you, and they really often have no one else to appropriately share that with. So you have an opportunity there that will be really helpful to them and to the patient. Next, it's just really important for you to remember, okay, what the patient wants is going to come first. Get that information from that referring provider, and then take your time to go through and figure out from the record, from the staff, how do we get here? How do we get to this place? And then look at, what are you going to do with that? How are you going to talk with a patient and a family when they have probably suspectedly been getting pressure from that provider to do that? And if they're frustrated, it means they weren't willing. So you already know that the provider's goal, get the DNR or go on hospice, and the patient family goal is wide apart. And so it's good to go in when you go to the patient and family and say, hey, what are the doctors telling you? What are the healthcare team telling you about how things are going? And often you'll get the same in your ear, which is they think we should go on hospice and they're withholding care. And just listen. And sometimes there will be real issues, and sometimes it will be subtext. But there can be racially charged issues. And I promise you that the basis for that is well-founded. It's well-founded in our community in West Michigan, and it exists to this day, that treatments are not offered for reasons that are rooted in systemic racism. And so just listen to see what's up. You, by listening, can learn, how did there get to be this big gap between what the referring provider, a caring healthcare person, and the patient family are at such odds about it? And sort through, is this misinformation? Is this lack of connection? Is this something different? And take the time to understand what the patient's wishes are or would be in the situation, to figure out, is there a subtext? I'm going to share an example of an interesting subtext of an African-American matriarch who was in her 80s and had a huge stroke and was maintained on the ventilator in the ICU. I'm going to share this as a poorly disguised real story, and you can't make this stuff up. And after 2 or 3 months on the ventilator with no progress, pupils are not blown, but not purposely responsive. And the intensivist and the attending physicians really want vent withdrawal. And the family absolutely refuse. And the family is complicated. There are 3 children plus one who's estranged and not present. One of the 3 children is routinely intoxicated or multi-product intoxicated when present. It's just very, very complicated. But when someone took the time to listen, here's what the issue was, why they did not want to make her no code or do vent withdrawal. All the children were living in her house except the estranged one, and they were living on her Social Security. And that was the patient's wish, that she care for her children. So that subtext, they had that conversation. The patient wanted to try any possible thing, and I did not identify any suffering associated with the mechanical ventilation. And so it took just some time to sort through with the family. She's not going to recover. What are we going to do next? And let's get ready for that. And by walking just step by step with some of the simple things, not trying to get the DNR or to get the vent withdrawal, but to say, you know, while we've got this time, what would she want her funeral to look like? And to get that kind of a thing in place. At some point, she will not survive this. Who's going to have to take care of her house and her things? And to help them kind of walk through that stuff. It took quite a long time, but truly no one had listened before to understand what the real subtext was. And the question about what the patient's wishes were in the situation was far more complicated than anybody had ever thought. So Ken, I've nattered on about it. Did that kind of drive at what you were asking?
Oh, absolutely. And I don't know, I've started kind of using the pretense of having no agenda when I go in for the first meeting, and also letting the family and patient know that. To just say, because sometimes they're immediately suspicious. You walk in and you're like, okay, what do you want? And or you know, you're just another person here to, you know, give me my non-goal concordant care, right? And so I think and that it also takes the pressure off, right? You don't have an agenda. You don't feel pressured yourself to keep pushing, you know. So yeah, but thank you. Good comments.
And I think that it's obligatory, and I didn't mention it, but I probably should, that you're going to have to go back to the referring provider and say, hey, I found out some new stuff, and I share your concern that this therapy is not medically beneficial, but I think we're going to need to take some time with this family and with this patient to sort this through. And so I want to let you know I'm working on what your goals are. I'm catching these goals. Be sure to document, but this would be the time when a face-to-face or a voice-to-voice conversation with the referring provider, let them know, hey, I heard what you said. Here's what I encountered. I think we're going to bring us together. It's just going to take me some time, can make a huge difference. And so recognizing that customer and the referring provider is in the situation is important, because the family probably perceives that referring provider, as Ken said, kind of pounding them about that same thing and not listening to them. And you kind of redeem that referring provider because they stop it. And they probably start to listen too. Really good. Well, we didn't get to any of my cases. I can take one more question if you have one, but our time is really up, and I know that you stick to your schedule pretty well. Is there any other question? I have really enjoyed speaking with you all. This is truly a privilege. I wish you all well in your day and in your week. and as you move on to the next part of your session. And one of these times, I hope to get to my cases.
Well, thank
So,
you, Barb.
thank you.
As always, appreciate the wisdom and the practical nature of your presentation. It's good stuff, and we really appreciate it.
Thank you. Good day, all.
Thank you.